Good afternoon, everyone. We're going to get started briefly, but we want to give everyone a moment to join as we prepare to conduct a webinar on understanding the social determinants of health to promote diversity, equity, and inclusion in our communities. I'm sorry, Aisha, go ahead.
You ready? I'm sorry. Well, greetings and welcome to the Understanding Social Determinants of Health to promote diversity, equity, and inclusion in communities webinar. Promoting diversity and supporting health equity have risen to the top of the priority list for many systems within our community. One of the most efficient ways to become more inclusive is by truly understanding the individual needs of those within our population and then meeting those needs with targeted, relevant programming, intervention, and policies. This understanding is possible using social determinants of health data, specifically questions from the social determinant of health survey from the All of Us research program will be used to guide this conversation this evening. Social work, public health, and pharmacy experts will share how they use this information to provide health care to the communities they serve. This webinar will allow involved experts practitioners to share insight and best practices to combat communities' ever-changing needs. Now, let me introduce our expert panelists. First, we have Ronald McLean. Ronald McLean is a licensed social worker who received a law degree from Loyola University in 2004. Mr. McLean is currently the executive director of the Institute of Mental Hygiene for the City of New Orleans. He previously served as president and chief executive officer of Family Services of Greater New Orleans for approximately 10 years. Mr. McLean also served for approximately 9 years as chief executive officer of the Children's Bureau of New Orleans. He served as the chair of the Long-Term Recovery Organization for Orleans Parish, which was called Crescent Alliance Recovery Effort, or CARE, and vice chair of the Greater New Orleans Disaster Recovery Partnership. Mr. McLean has worked with children and families in need for over 30 years. He has been a frequent speaker and trainer in the social services arena. He is past president of the board of directors of Loyola University's Lindy Boggs National Center for Community Literacy and has served on the board of directors of Agenda for Children. Over the years, Mr. McLean has provided direct services as a psychotherapist in addition to clinical supervision and program management and administration. He has been the adjunct faculty at Southern University at New Orleans School of Social Work for approximately 20 years. He was honored by the National Association of Social Workers New Orleans Regions as the 2012 Social Worker of the Year. He was also selected as the NASW Louisiana Chapter Statewide Social Worker of the Year for 2003. Additionally, Mr. McLean was the recipient of the New Orleans Association of Black Social Workers Annual Founders Day Award for 1991. He is currently Vice President of the National Association of Social Workers Louisiana Chapter. He specializes in nonprofits, mediation, risk management, staff development, and training, community clinical practice social work, and ethics training. Welcome, Mr. McLean. Next, we have Dr. Billy Castle. Dr. Billy Castle is an assistant professor, public health services at the University of Louisiana. Dr. Billy Castle, a native of Baton Rouge, graduated with a Bachelor's of Science in Health Sciences from Howard University, Master of Public Health and Health Policy and Management from Texas A&M University, and Doctor of Philosophy in Public Health Sciences with a concentration in Health Promotion and Behavioral Sciences from the University of Louisville School of Public Health and Information Sciences. She completed a postdoctoral research fellowship at the University of Louisiana Center for Disease Control and Prevention, designated Youth Violence Prevention Center. Her research focuses on the reducing social, health, and racial disparities in Black communities by addressing the impact historical policies have had on the environment in which we live through community engagement and equitable policy implementation. Currently, Dr. Castle serves as an assistant professor in Public Health Services Department at Xavier University of Louisiana. She has research experience in the areas of youth violence prevention, social justice youth development, health equity policy and practice, and community engagement as a means for community change. Her current projects include understanding New Orleans youth development ecosystem, connecting public health data to social determinants of health data for action, and understanding communities' perspective of research. Welcome, Dr. Castle. And last, we have Dr. Christopher Gillard. Dr. Christopher Gillard is Clinical Associate Professor at Xavier University College of Pharmacy. After earning his degree of pharmacy, after earning his Doctor of Pharmacy degree, he completed a pharmacy practice residency with Xavier and LSU Health Sciences Center in New Orleans. Dr. Gillard currently teaches topics on cardiovascular disease management in the College of Pharmacy at Xavier University of Louisiana. Dr. Gillard is a board-certified pharmacotherapy specialist and is an internal medicine clinical pharmacist at the University Medical Center of New Orleans. Welcome, Dr. Christopher Gillard. Now I will turn it over to Ms. Nadia James. Thank you.
Thank you so much. So I just want to tell the attendees to please just be aware that the panelist questions are centered around questions taken from the All of Us Research Hub Social Determinants of Health survey, which includes 80 questions. There were 117,899 participants who completed this survey. So we're going to go ahead and get started with our first question, and we're going to start with Jay.
Warm greetings and humble salutations, beautiful people. We are so excited to have you join us today for us to discuss some social determinants of health, which is really pertinent with the All of Us program, especially amongst our Black and Brown people more specifically. So I'm really excited that we have these panelists who are availing their expertise to us on this evening. And I hope that you all gather all of the resources that are available to you. But nonetheless, let's go ahead and get started. I do believe in punctuality, and we want to get you out of here and get the information that you need. Sounds good? Awesome. So my first question is going to be for Dr. Castle. Dr. Castle, your research has focused on reducing social health and racial disparities in Black communities by addressing the impact historical policies have had on the environment in which we live through community engagement and equitable policy implementation. One question from the survey discussed mainly abandoned buildings in one's neighborhood. And I know all too well in New Orleans, you can jump from one street to the next and life expectancy is totally different, right? And so my question for you would be, how does substandard housing, abandoned buildings, and vacant or poorly maintained lots affect one's health and well-being?
Thank you. So first, thank you all for the invitation to speak today. I'm so excited to share this panel with other colleagues to talk about these important topics. And first, I want to just start off with, since we are talking about the social determinants of health, Healthy People 2030 organizes the social determinants of health, which are the conditions in the environments where people are born, live, learn, work, play, worship, and age that affect a wide range of health, functioning, and quality of life outcomes and risk. And they separate them into 5 domains: economic stability, education access and quality, healthcare access and quality, neighborhood and built environment, in the social and community context. So in this question where you're talking about how does substandard housing impact us, we're really focusing on that neighborhood and built environment. And as you mentioned, your zip code determines your health outcomes. And so when we talk about our zip code determining our health outcomes, I added a link where everyone can put in your address and you can see what the average life expectancy rate is right now for where you live and how it compares to other communities as well as our city, the state, and the nation. And I like to keep those interactive tools even in class so that we can all just look and see, based on your everyday life, what's happening around you. And so when we know that some zip codes have drastic differences between their life expectancy. So there are zip codes in New Orleans where the average is 10 years lower than what it is of the city, the state, and the nation. And so when we talk about that neighborhood and built environment and the conditions where your home is and the quality of those social and physical environments in your homes. Poor housing quality is associated with a lot of different negative health outcomes, such as chronic diseases, injury. If it's an older home, which I know we have some older homes here in the city, it leads the presence of lead, mold, or asbestos, poor air quality. So even if you are living close to an interstate, or if you live close to plants, because we know there are a lot of neighborhoods, not even just in New Orleans, but as we think about our neighboring parishes in Cancer Alley, how that impacts our physical health, our mental health, chronic and infectious diseases. Really, if we overlay different maps over our zip codes and health outcomes, we can see a lot of the same communities are impacted. And in my bio, it talks about how I like to think about historical policies, because the way in which people are answering the All of Us surveys, if we look at and group them by different zip codes, a lot of people are experiencing the same thing across the country, because their communities have some of the same characteristics. And a lot of that, in a lot of housing disparities we see, can be traced back to decades-long legacy of governmental, institutional, and interpersonal discriminatory policies and practices, such as redlining, urban renewal, and even now gentrification. A lot of these policies are masked as trying to help our community or change the way in which we are experiencing those abandoned houses, vacant lots. But a lot of times it's really disrupting the community in which a lot of us have built and the relationships we have with each other. And so when we think about how they're impacting our health, the quality of our neighborhoods are directly impacted by those policies that I mentioned. And so a lot of that is still happening, because a lot of people like to think, okay, redlining, that happened almost 90 years ago. Urban renewal, maybe 60 years ago. But we still see a lot of these discriminatory practices happening when we see Black families, when their homes are being appraised, they're being appraised less than what white family homes are being appraised for. So housing issues impact us across socioeconomic status. When we think about it in terms of like race and institutional practices, but also for communities where we're seeing a concentration of low income homes and people who have lower incomes and poverty. A lot of the things that they're in, the physical and emotional health, including like access to sidewalks and parks, really are impacting our long-term health and health outcomes. So there are some simple solutions when we think about it. We have the data. Like I said, we can look at and pinpoint through zip codes where we are impacted the most by a lot of this blight. And we have ways we can solve it. So thinking about just something as making sure that street lights are working, making sure that the sidewalks are walkable, making sure that trash is picked up regularly, which I know a lot of us here in New Orleans, we have a lot of issues sometimes around our trash pickup and the things that are out. So we have to think about the data, not just from All of Us, which gives us a lot of the people's experiences and how we can use the voice of community to understand not only what's happening in an everyday around them and how they see it in their environment, in the environments in which we are supposed to really love and nurture, and how many of them have been underinvested in and neglected. And so now we do see these conditions, and we have to have really intentional policies and investments, such as like the American Rescue Plan funds that were specific for communities that were impacted mostly by COVID. But again, if we overlay those maps of the communities that are most impacted by crime, violence, different chronic disease. So if we think about it from the terms of like diabetes, heart disease, all of these things, our communities consistently are showing what's happening. If we really think about honing in on changing the social and environmental issues, we can make generational changes and really change health outcomes for generations to come. So I really want us to think about how we can use this data to change and to make environmental physical changes so we can improve our health outcomes.
Thank you, Dr. Castle. I think I just want to go ahead and chime in on that in support of what you are saying. One thing I really appreciate about the Dr. Millie M. Charles School of Social Work House at Southern University at New Orleans is that they're going to teach you, all right? And so the thing that I heard is that there is latent goals beyond the policies that are administered, right? Or the policies in which you say that you're enacting for the betterment or for the advancement of equity and for lifespan, right? Totally. But simple things like sidewalks and parks and greenery, making sure that there are community schools that are supporting young people. I think that's very much so imperative. And while you did mention the data, I think it's very important that we do not limit ourselves to just that data that avails, because I do think still we do miss certain pockets of people when we just magnify our concentrations on the data that is allotted for us to review, right? So really thank you for that contribution. Nadia, I'll hand it over to you.
Thank you so much. And thank you, Dr. Castle. It was such great information that you shared with us. You actually touched on a cardiovascular topic. So with that, I'm going to go ahead and focus on Dr. Gillard. And while we're here, happy Heart Health Month to you, Dr. Gillard, and to everyone else on the call. So Dr. Gillard, currently you teach topics on cardiovascular disease management in the College of Pharmacy at Xavier University of Louisiana. So as a New Orleans native, growing up in the Lower Ninth Ward, I can attest to this. In many socially deprived communities, there are like corner stores, mini markets, and other places to buy not so healthy things within easy walking distance. My question for you is, how do neighborhood resources such as these impact cardiovascular disease?
Okay, thank you for that question, Nadia, and I'm happy to be a part of the panel with everyone this afternoon. There are several different impacts that can exist with cardiovascular disease. The first thing we have to talk about is what actually impacts cardiac disease or cardiovascular disease. One of the things we try to reduce the risk of in our patients is to reduce the risk of heart attacks and strokes, which are our most devastating cardiac diseases that we have. The major risk factors for those things happening are high blood pressure, high cholesterol, and also diabetes. And it's important that we also understand that it's easy to provide medications to patients to lower their blood pressure, cholesterol, and control their blood sugar. But at the same time, lifestyle changes are as important as medications such as diet and exercise. As far as people in our communities, they need access to nutritious and healthy foods in safe areas of physical activity. One of the challenges we have in our Black and Brown communities is we have food deserts. So what is a food desert? Food deserts are described as geographic areas where residents' access to affordable, healthy food options like fruit and vegetables is restricted or non-existent due to absence of grocery stores within a good traveling distance by walking or by bus or short car distance. And this is a pretty serious problem. Now that you mentioned the Ninth Ward, and the Ninth Ward is indeed in a food desert. Some areas of New Orleans are in a food desert. The evidence indicates that food deserts are more common in underserved communities in minority areas of Black and Brown communities. Unfortunately, this is a very big challenge. In fact, 1 out of 5 Black households is in a food desert with few grocery stores, restaurants, and farmers markets. So this has a negative impact on cardiac disease. So our patients, our members of our Black and Brown communities don't have access to fruit and vegetables, although our healthcare providers will say, you know, you have to lose weight or eat more veggies. But what if you don't have access? That is a big challenge. You know, that's a very big challenge that our communities need to know about, and also our healthcare providers need to know about as well. And also there's something called food insecurity. So here we have limited or uncertain access to adequate food because of economic or social reasons. So how can I take evidence or advice from a doctor to eat healthy when I don't even know what my next meal will come from, whatever it is? So there are definitely quite a few challenges there that impact cardiac disease in our communities. So what do we do with this information? First of all, it's important to know where food deserts exist, and there's information online that can help with that as well. And Dr. Cass talked about looking at things by zip code. You can determine zip codes, food deserts by zip codes as well. So for example, without even me looking, areas like New Orleans East and Ninth Ward are going to be in food deserts compared to more urban suburban areas such as Metairie or Kenner. You know, so there's quite a difference there as far as access is concerned. So things we can use to support our communities as far as this is concerned. The American Heart Association has websites about how to eat healthy on a budget, and that link will be coming up in the chat as well too. And also the American Dyslipidemia Association, our cholesterol experts provide information about how to eat healthy on a budget as well. So those are things that are very important. And also, not to mention physical activity. We've talked about not having access to sidewalks. Believe it or not, 30 minutes, at least 5 days a week, can have a positive impact. But physical activity, exercise, can have a positive impact in lowering your blood pressure and also impacting weight. So physical activity is a big piece as well. And there may be some challenges that exist in our communities. So how can I get out and exercise when I'm really concerned about the crime or something happened to me when I'm outside doing exercises? So physical activity is something that's important as well. So the key things here that impact our communities are food deserts and lack of physical activities or being able to do physical activity. So in the chat, you will see some things about eating healthy while on a budget.
Wow, thank you so much. Such great information. We're going to go ahead and pass it to Jay so he can ask the next question.
Thank you so much. Indeed, very good information. Thank you for that contribution, Dr. Gillard. The next question is going to be for, well, I see McLean, and McLean, I see JD. That's a doctor of jurisprudence. So I'm going to say Dr. McLean, all right? That's how we're going to proceed with that further. But nonetheless, we're going into crime. We're going into crime. And the city of New Orleans, of course, is not a unique city to deal with that. And while I do see the question here, I'm going to kind of navigate a few things in this thing so you can go ahead and tackle that, right? But Dr. McLean, you are a licensed clinical social worker and the executive director of the Institute of Mental Hygiene of the City of New Orleans, or IMH. The social determinants of health survey address crime rates within neighborhoods, and individuals can experience different types of violence throughout their lifespan, and adverse health effects on violence can occur at any age. Now, this is the question, but I'm also going to segue some of my stuff in there, okay?
All right.
So while crime and violence can affect anyone, certain groups of people are more likely to be exposed to it, right? The first question is going to be, can you elaborate on this and identify these groups? But if you can also touch on the reason in which we even have these violent crimes in the first place. I think that we often do talk about victim, which is not wrong at all. We do need victim advocacy, right? However, when we are talking about what those signs are to look out for with the youth, or when we talk about when I ran for office the first time, I told the folks that whenever the economy changes or education sector changes, people's behavior starts to change. And so I think that's honestly what we're seeing out here. But to address that mental health component within them, one, addressing the victims, and then two, having a conversation about the reason that these violent occurrences are even happening.
Wow. Thanks so much, Jay Christopher. And also thanks to Xavier University and Southern University at New Orleans, two HBCUs that have come together to kind of put this program on. I'm so excited to be a part of it. I have history, obviously, with Southern University, SUNO School of Social Work, being the first graduating class of the master's program. And also with Xavier, I spent many, many years and continually kind of go to Xavier. My wife has worked there for over 30 years. And so it's another home to me. So thanks so much for putting this on. And yeah, sometimes I think about this whole issue in the context of some of the things I used to teach at SUNO years ago about person and environment. Can't do this work without understanding the context that people live in and grow in and love in. And so Jay Christopher asked a very, very good question. So, and you know, the answer is it's pretty clear that while crime and violence impacts everybody, a lot of people, certain groups of people are certainly more likely to be exposed. And those people are folks that unfortunately will show up in each one of our talks about how, you know, certain populations are impacted so much by the social determinants of health that we have to pay a lot more attention to it. So those groups that are, the research indicates that those groups who are most likely to experience crime and violence are young, Black, male, and poor. Yeah, young people, Black people, males, and poor people are disproportionately impacted as victims of crime. For example, the national homicide rate is consistently higher for Black adolescents than they are for young adults than their white counterparts. So young Black adults are much more likely to be victims of homicides than their white counterparts. The Bureau of Justice Statistics have conducted on an annual basis a national crime victim survey. They ask random questions about Americans' experience with crime, and ask these questions to folks 12 and older. The data from these surveys reveal that those with households below $7,500 are much more likely, some 3 times more likely, to be robbed than those with incomes above $75,000. Now, that might seem counterintuitive. You would think that people with more money, more resources, would more likely to be targeted by criminals. Well, the facts are a lot of people with wealth do have stuff. But poor people are more likely to live in high crime neighborhoods, and criminals typically victimize those around them the most. It's more convenient for them. Poor people are not just more likely to be robbed. Those at the lowest income levels are victims of aggravated assault at a rate of 13 times per 1,000, compared with 3 times per 1,000 for those with a $75,000 or more income. So we're talking about poor people not only being more likely to be robbed, but also more likely to be assaulted with weapons, guns, knives, bats, and others. Low-income neighborhoods are more likely to be affected by crime, property crime, as well as personal crime than high-income neighborhoods. Types of violence include, but are not limited to, child abuse and neglect, firearm violence, intimate partner violence, sexual violence, and yes, elder abuse as well. In addition to the potential for death, disability, and other injuries, people who survive violent crime endure physical pain and suffering, and may also experience mental distress and reduced quality of life. Specific examples of detrimental health effects from exposure to violence and crime includes asthma, hypertension, cancer, stroke, and mental disorders. So it's, you know, it impacts physical health as well as mental health, just living in certain neighborhoods and being a part of certain populations that I've named before. Decades of research has established a connection between adverse childhood experiences, ACEs, which many of us have learned about, and this connection between these experience early on in children's lives and violence and abuse and later on life. So those people who are impacted by adverse childhood experiences are also more likely to be impacted by violence later on in life. But not only violence, also health concerns, chronic health concerns, diseases, and also mental disorders. So it's really important to think about the fact that, just to repeat, that young, poor Black males are disproportionately impacted as victims of crime. And there's a number of crimes that they experience. And oftentimes we don't think about the fact that Black males are victims more so than they're perpetrators. The general media, looking at the metro section of the newspaper, the news would have you think that Black males are super predators and always are perpetrators of crime. and in some cases they are perpetrators of crime, but more likely they're victims of crime. And that's something to think about as we kind of think about the most important strategies for responding to these challenges.
So there was a theme there, and I don't think that some of these things are exclusive to one another. But the biggest thing that I heard was adverse childhood experiences. But then I heard young, Black, male, and poor, which each one of those are respective in their own capacities and categories, right? However, we're down here, all right, now it seems that folks encompass all of those, right? And even when we talk about what's happening on the state level right now, because policy affects all of this, right? And we're talking about the criminal injustice system in this special session that has been prompted by Governor Jeff Landry, okay? And we have folks who are rushing through committee. We have folks who are trying to bypass time because they know these bills are bad. But when we're trying to lower ages to try young people as adults, when we already reversed that under the Bell Edwards administration, when we're trying to bring back nitrogen oxide for the death penalty, these things have a disproportionate effect on us as Black folk. I'm young, male, and I ain't rich.
G.A. Christopher,
Yes, sir.
those policies are not based on the data. That, in fact, they're just the opposite of what the data might indicate as the most appropriate responses to crime and violence, and how we best serve our young people who might find themselves in a justice system. And so we have a lot of work to do. And one of the things you said early on about policy is so important. And good data makes good policy. And so that's a part of the strategy that we have to use, gathering the data, looking at the research, the things that Dr. Castle talked about, the things that that Dr. Guillard talked about. Those are data that we have to use in order to affect good policy. And God forbid, we have a lot of work to do based on what you've just talked about. This special session is ripe with strategies that are not consistent with the data and are not in the best interest, and are really counterproductive to looking at diversity, equity, and inclusion and the social determinants of health.
So I'll actually be at the Capitol tomorrow lobbying and testifying in front of committee. So I'm going to bring this data with me, Doc, so some of these lawmakers and legislators can familiarize themselves. Nadia?
Thank you so much, Mr. McLean. Such great information. You actually touched on something that was that stood out to me as well when you mentioned the basically the child abuse and things like that. I'm actually going to go forward and do some research, qualitative research this semester on how child abuse impacts adults later in life, you know, how those survivors are dealing with some internal things. So definitely felt that that was worth mentioning for sure. So going forward, my next question is for Dr. Castle. Dr. Castle, I love the fact that your research interest is around Black communities and historical policies. According to Gallup, Black Americans at 60% are less likely than all other racial groups in the US to say that they feel safe walking alone at night in the area where they live. This leaves 4 in 10 Black Americans saying that they do not feel safe walking alone under those circumstances. The Social Determinants of Health survey address crime rates in neighborhoods and feeling safe to walk during the day hour. My question for you, Dr. Castle, is what impact does this have on a person's physical health and emotional wellness?
Thank you. And I would say a lot of what I was going to mention, Dr. McClain just mentioned, because all of these things are absolutely connected as we talk about food and food access and how does that impact like cardiovascular disease and mental health. Like everything that we're talking about is connected. And so when we talk about, how does crime impact our physical well-being, I definitely like to talk about things from that asset base instead of from a deficit base, because how we frame things is how we view them. And so when I think about it, we are meant to be in community, we're meant to socialize, we're meant to connect, we're meant to interact, because another important part of those social determinants of health we see is a social and community context, because we know that it is taking community for us to thrive and make it through many of our generations. So we are meant to move, to feel the air, to breathe it, and to be around each other. And so for us to feel as if a lot of people feel like cannot walk in their neighborhood, we have to understand the conditions that are impacting our health. And a lot of times we talk about physical health, but we need to talk about our spiritual health, our emotional health, and our mental health as well. So that means that we're not interacting leisurely in our environment, and we need to. Like Black leisure, I know there's a movement about talking about Black joy and thinking about those things, but getting back to what Dr. McClain mentioned regarding how the numbers of people who are actually, of Black males who are actually the victims more than the perpetrators, we have to think about how the narratives that have been created impact the way in which even we view and interact in community. So not being able to be out in your community walking, or not having access to parks, or going to the park, or just walking down the block, means we are seeing higher rates of obesity, chronic diseases, and reports of depression. I think over the pandemic, we saw higher rates of depression reported, and especially thinking about how it's impacted adolescents and teens. I think that gives us a that we have to really pay attention to how do we change our physical environments so that we are continuing to build community. We're continuing to move together and get out and plant in gardens and see kids playing in the street and all those things. And so just as we talked about that connection between the current policy session and how those policies directly impact our health, we have to also think about how are we looking at health in all policies and the impact that a lot of these policies will have on health outcomes. And so why can't we think about addressing those root causes such as poverty? Why can't we have a session on increasing minimum wage? Why can't we have a session on increasing the housing shortages? We need to think about strengthening community environments. I think there's way too much attention drawn on some of the outcomes and not a lot on the root causes. So when we talk about how we need to invest in public safety, that doesn't just mean investing in the police and making sure we have more police, but the definition of public safety is really thinking about how we all move around in the public safely. So again, street lights, fixing the streets. How many of us driving around New Orleans are hitting potholes? Fixing sidewalks and thinking about the actual physical environment are the things we need to focus on. Addressing food deserts, as we talked about earlier, and public transportation options. How can we reduce how many cars are on the street by making more bike lanes and having public transportation more accessible and affordable, and running at a time that's consistent enough to where people can get where they need to go, work, leisure activities, all these other things. As we see people focusing on carjacking, can the automotive industries teach the youth skills to build cars and newer technology? Like, why do we have to always think about things from the deficit instead of being innovative and thinking about it from the asset base and making those structural changes to our environments that make for better outcomes for all people? Because a lot of times, when people hear about equity and change, it's like there's a misconception that equity is taking away from one group to give to another group. But when we have change, this is for all of us. We all deserve to live in a healthy and happy society and communities. So the changes that we're talking about will benefit everyone's health outcomes.
Excellent response. Thank you so much, Dr. Castle. I'm gonna go ahead and pass it on to Jay.
Thank you. My next question is going to be, of course, for Dr. Gillard, being that we are in this order. And this question it's just funny to me. Okay, not funny, but we say it's funny. You get what I'm saying. So as a board certified pharmacotherapy specialist, you are aware that pharmacotherapy is a treatment of health conditions by using pharmaceutical products or drugs as medication. When the health condition is a drug dependency, pharmacotherapy involves replacing the drug of dependence with a legally prescribed substitute. The survey highlighted a question that focused on being treated with less courtesy than other people when you go to the doctor's office or other healthcare providers. The reason this is funny, to me at least, is number one, folks still don't believe that Black people feel pain. That's a thing. And then when we're talking about a street pharmaceutical drug and a prescription pharmaceutical drug, that thing also has the potential and possibility to be addiction dependent on it, right? And so honestly, many of those things that are in the pharmacy are some of those things that are just used on the street as well. Right. And so I want you to kind of get into that as well. But for millions of Black people and other people of color in the United States, racial bias is a very real experience. And so how does this lead to serious healthcare disparities?
Yes, thank you. That's a great question. Racial disparities in health can be explained by racial bias. Racial bias leads to more resistance in providing the most effective care to certain patient groups. So, there's more of a resistance to provide care to certain groups for conscious bias and also unconscious bias, unfortunately. So some providers may not see certain groups, primarily Black and Brown communities, as being able to participate or tolerate complex treatment regimens compared to other groups just based on perceptions, not based on evidence. And do we have evidence of it? A study published in the Journal of the American Heart Association, a 15-year study showed that African Americans were less likely to receive several evidence-based therapies to treat and prevent heart attacks that have been proven to reduce the risk of death and additional adverse cardiac events. That's published. Another study showed that, a published study showed that about 400 hospitals in the country showed that Black patients with heart disease received older, cheaper, and more conservative treatments than their white counterparts. Also, Black patients are less likely to receive cardiovascular procedures when presenting with heart attack symptoms like coronary bypass operations or angiography, where we look at the heart vessels. Even if our African American patients have the surgery, there's data to show that they are typically discharged earlier from the hospital than white patients, and in some cases, that's not appropriate. You talked about pain, chronic pain conditions that well studied that African Americans are undertreated for pain, and that there's the thought that African Americans have a higher pain tolerance. That's published as well. We talk about sickle cell disease patients. Those patients often report they feel undertreated for their condition and their pain is not adequately controlled. So overall, there's a lot of data that unconscious and conscious bias has a negative impact on healthcare among Black and Brown communities. And this is tough because, a lot of us cannot control that. It's some things that needs to be done in our healthcare system to assess this. For example, I know in most medical schools right now that medical students are required to take a course in cultural competence. That's good. That's a good thing. That's a good step, but still bias does exist. So what do we do in these situations? It's a challenge. One thing I would recommend is taking a family member to your doctor's visits can help. Like I'll always give my own perspective. My parents, I'm the only child of aging parents. So when I can't get off, if I can get off of work, I'm at the doctor's office right next to my mom and my dad. If I can't get off work, put me on the phone so I can hear what's going on. So having a family member there, or having someone we trust with our healthcare decisions is one piece, so they can see a different perspective from ourselves can help. Also, so many things happen when we go to the doctor's office, and it can be overwhelming. It's important for us in our community to write down our questions and concerns before seeing providers. And also, we have to realize, although healthcare providers are very busy with a lot of patients, our time is as important as everyone else in their doctor's office. So those are some early things we can do to hopefully have a positive healthcare experience.
Thank you for that. I picked up on unconscious and conscious bias, right? And with all due respect, while I do understand that's underlying, these folks are racist, okay? I think that we need to call it out. These folks are racist because I think that when we change the tone of certain things, we neglect how we should be approaching some of these solutions because we have lessened the severity of what it is. And as you were mentioning, cultural competency is very much so limiting, but I don't hear much talk about cultural sensitivity to implement the cultural competency. You can know it all you want, but applying that thing looks totally different. And I also feel that when we're talking about DEI, diversity, equity, and inclusion, I tell folk all the time, it ain't my job to undo racism because I didn't cause it. My people didn't cause it. But I feel like there's a lot of discrepancies when we have people who are doing DEI that may not necessarily look like us, but are informing other people and training other people about how to care for us or interact with us, right? So I just wanted to contribute that to conversation, and I'll yield it back to Nadia.
Thank you. Thank you. So, Dr. Gillard, you mentioned systemic racism. You talked about how basically these trainings, that's one thing, but systemic racism is a real thing, and it goes way deeper than training, right? So that's going to lead me to my next question for Mr. McLean. Okay, Mr. McLean, in your work, you encounter clients that are feeling unhappy and that are often withdrawn. Race-based trauma or race-based traumatic stress refers to the emotional and mental injuries that result from continued exposure to racism, ethnic discrimination, racial bias, and hate crimes. The high rate of people who experience racism and subsequent racial trauma highlights the need to address the terrible nature of systemic racism in the United States. So with that, what impact does racial trauma have on the Black community?
Well, a lot. It's huge. I talked earlier about adverse childhood experiences, and the original study was done by Dr. Vince Felitti and Robert Ander out of Kaiser Permanente in San Diego and San Francisco as well. But Philadelphia has revised ACEs kind of strategies, and they have added racism and racial trauma to one of those adverse childhood experiences. And we know that these adverse childhood experience, have a trajectory that impacts morbidity, a lot of sort of illnesses, and also early mortality. And so it's really important, and I'm glad you asked that question, Nadia, particularly in context of next month being Mental Health Awareness Month, that we need to be aware of all of these things and how racial trauma impacts our mental health. And so any individual that has experienced an emotional, painful, sudden, and uncontrollable racist encounter is at risk of suffering from a race-based traumatic stress injury, as Nadia has indicated, and either mental and emotional injuries by encounters with racial bias, racism, and hate crime. In the United States, Black and Indigenous people of color are most vulnerable to this racial trauma and this race-based traumatic stress because they live in conditions under a system of white supremacy. Racialized trauma can come directly from other people, or it can be experienced within a wider system. And many of us has talked and experienced systemic racism. We understand that it's within our society, within the environments that people live and work and grow. And so it's important to pay attention to that. It can come again from this direct experience with racism that's enacted on you, but we can also pick up this racial trauma vicariously, such as when we see videos of other people facing racism. When we look at all those old movies, God forbid, many of us experiencing, those feelings. When we look at Roots and other movies that have direct examples of racism, racial bias, and people being actually injured because of racism. The experiences of race-based discrimination can have detrimental psychological impacts on individuals and their wider communities. In some individuals, prolonged incidences of racism can lead to symptoms like those experienced by folks with post-traumatic stress disorders. Yes, they can have PTSD just by living in this community and living in this environment because of the systemic and historical racism. This can look like depression, anger, recurring thoughts of the event, this racial encounter, physical reactions even like headaches, chest pains, insomnia, hypervigilance, low self-esteem, and also mentally distancing from the traumatic events. Despite progress made over the years, racism continues to have an impact on mental health, particularly in the Black community. Negative stereotypes and attitudes of rejection have decreased, but continue to occur with measurable adverse consequences. Historical and contemporary instances of negative treatment have led to a mistrust of authorities. And we see that all over. We are just not trusting of authorities that have subjected us to the kind of situation that we find ourselves in, where the only reason why we have these negative experiences is because of our race. So many of us, have come to the point where we sort of mistrust the authorities, and so we need more information. Sometimes we don't see authorities as having our best interests at heart, or the best interests of African-American people at heart. And this creates a particularly challenging situation for us and mental health professionals. The challenge is that there's not nearly as many Black mental health professionals as we need. And so we're looking at strategies to have more people empowered and build that capacity, people with lived experience, people who are trusted folks within the community to be a part of the system of care. One program at Southern University right now is the Community Healers Collaborative, in which we were able to provide the funding for an Institute of Mental Hygiene, where more people who are coaches other than the community are trained on mental health first aid, so they can begin to interface with people having some concerns, and also have the information necessary to direct them to a more robust clinical interventions, like psychotherapists. And we'll talk about that a little bit later. But it's important to recognize that that racism has a negative mental health impact, and it is an adverse experience for us, and it leads to mistrust of the authorities.
Thank you so much for that. I'm going to go ahead and pass it to Jay.
Thank you. And panelists, I'm a preacher as well, and I understand when they say 2 minutes, okay? And so we're nearing that end of time. And so for these remaining questions, I do ask if you can stay within a 2-minute time frame, okay? But my next question is going to be for Dr. Castle. Your research also focused on health equity policy and practice as a means for community change. The survey presented a question that addressed how often a doctor or a nurse acts as if they are afraid of a patient. Now, my question would be, which practitioners are afraid? Okay. And from my understanding, doctors and nurses take an oath to do no harm. Right. And so my personal, question is, are they really afraid, or have they allowed their bias to over exaggerate human behavior and taint their ability to serve? But that's just me. But the question is, why are certain groups of patients getting this type of treatment from our healthcare professionals? And can you elaborate?
Yeah, and so I wouldn't just give it to them on the individual level. I would think about it more institutional. But I think for beginning off, I have to name like Sarah Bartman, the gruesome experiments on enslaved people, Henrietta Lacks, the Tuskegee experiment, Minnie Lee and Mary Alice Ralph, and the countless women who were involuntarily sterilized, and the countless patients who are undertreated for pain relative to white patients who these are just a few examples of things that have contributed to why especially Black patients feel as if, or those are direct examples as to why they are mistreated. And if we talk about bias, I know sometimes people like to only put it on one race, but we have to think about it from, again, the institutional perspective of healthcare organizations as a whole. So when we talk about patients not trusting healthcare professionals and being labeled as non-compliant and blamed for the failure to benefit from the treatment, a lot of it goes back to just the embeddedness of bias as well as assumptions and stereotypes in trainings. So to make this change, I would say we need to even start before medical school, having students read historical things like the Flexner Report and other historical documents to understand not only the foundations of their fields and how we got here, but to also understand the experiences of the groups who are continuously identifying that there is a problem. So we have studies like All of Us and other examples of data of community talking about their experiences. So we need to use a lot of that education even in undergrad, but we see in high schools where there are medical programs, but we need to go back and really unearth those stereotypes and assumptions that are embedded within the curriculum and make sure that moving forward, institutions not only acknowledge the impact of institutional and systemic racism, and how the impact it's had on how care is delivered and how patients are treated and perceived, but also how moving forward we are going to make sure that we are not only culturally sensitive and have cultural competency, but we also have compassion, and we are looking at this from a holistic perspective of how can we all work together as healthcare professionals to change those health outcomes and make those really big sweeping changes we need to make sure that people have what they need to be healthy and whole. In my 2 minutes.
No, you did that. You did that. Listen, I believe that history doesn't repeat itself. It continues, and social media is just showing us that, the medical mistrust is continuing. We can see in COVID where the mass vaccinations, right? And people are not wanting to do that. But what I did hear that was paramount was systematic change and institutional change as the fish rots from the head. And I'll pass it back over to Nadia.
Thank you. So again, going to just remind you guys of the 2 minutes. I have Dr. Freeman just telling me, let's sum it up in 2 minutes. Okay. So Dr. Gillard, this question is for you. So in a study published by Pew Research Center in 2022, when participants were asked about their healthcare experiences, most Black Americans had positive assessments of the quality of care they received most recently. However, a majority, about 55%, say that they've had at least one of 6 negative experiences, including having to speak up to get the proper care they needed and being treated with less respect than other patients. The All of Us Social Determinants of Health addressed this same question in their survey. Experts have pointed to several contributing factors to disparities in health outcomes for Black Americans. Dr. Gillard, what are the key factors in health disparities for Black and Brown Americans?
Sure, and I think we've talked about several of these tonight. We talk about the social determinants of health. So economic stability is one. So if we have unstable jobs or less likely to receive financial assistance, that leads to more physical and psychological stress. That can lead to unhealthy living conditions. Our environment, so we're in areas where there's housing insecurity or more crime, that can lead to physical inactivity. Education. So education is a challenge in some of our communities, and that can lead to reduced health literacy or knowing why we're taking medications and certain things for our health. Also, we talked about food. So food insecurity and food deserts, we talked about that tonight. That can lead to unhealthy diets. And also, we've talked about the healthcare system and the implicit bias that exists. So where we go from here is to, first of all, being aware that these things exist and navigating how to improve these things if we can. So major social determinants of health, such as poverty, income inequality, food insecurity, and lack of safe, affordable housing are big parts that lead to health disparities in Black and Brown Americans. And also I'll add as well, too, that when we talk about healthcare provider mistrust, healthcare provider mistrust, I think, is actually underestimated among Black and Brown communities as well. And I think COVID shed a light on that as well, too.
Absolutely. Thank you so much for that. Jay?
Last but certainly not least, Dr. McLean, you have worked significantly with clients struggling with daily personal issues. And again, the Pew Research Center in 2002 posted that a substantial share of Black Americans say that when something happens to them or Black people in their local communities across the nation or around the globe, it affects what happens in their lives, highlighting the sense of connectedness. Black Americans say that this even as they have diverse experiences and come from an array of backgrounds. The social determinants of health survey address feeling confident about one's ability to handle personal problems. I believe that we all go through the same thing, just experience it differently, all right? And those things that don't affect us directly has an indirect impact on us, especially the most marginalized and disenfranchised populations of people. But this is a two-part question. The first one is going to be, what are your views on using informal coping mechanisms for family, friends, church, because we like to go talk to the pastor like he's a clinician, to address personal problems? And when must a person seek professional help from a licensed professional or practitioner to address their challenges and so on?
Well, thanks so much, Jay Christopher. Well, yeah, informal support networks have been used traditionally by African Americans and with a lot of positive effects. In fact, informal support networks can serve as protective factors for a variety of well-being outcomes, things like psychological, physical, and economic well-being. And family support, in particular, is related to higher levels of life satisfaction, lower mortality risk, and improved standards of living. Those who provide informal support, they're pivotal because they can typically provide direct assistance in response to stressful life events, deaths of loved ones, other traumatic events. But they can also help kind of determine when there's the need for a referral to for more professional help. These informal assistants, they can help, but sometimes they're insufficient to address a problem. And that's where there's a need for more formal interventions. And for Black people in particular are far less likely to seek help. Statistics tell us that about 25% of African Americans seek mental health treatment compared to some 40% of white Americans. Unequal access to healthcare, and many of the panelists have talked about this before, that there's a lot of problems with the access and availability of healthcare, mental health care in our community. And some of it's related to racism and how there's problems on the other side with people who are providing the care. Nearly 10% of Black people in the United States do not have health insurance, so that's an access issue, compared with 5.2% of non-Hispanic white people. When members of the Black community do seek help, however, they are more likely to receive it from the emergency room, emergency department, less likely to have regular sort of ongoing support. They're more likely to be much more ill and sick when they seek help. But each mental health condition has its own signs and symptoms. In general, however, professionals' help may be needed if you experience marked changes in personality, eating or sleeping patterns, and inability to cope with problems on a daily basis. I often say that you might need some support when you have problems with social functioning. Now, what's social functioning? Social functioning is the ability to get your basic needs met, and also the ability to perform desired social roles like being a parent, being a worker, being a friend. So when these things are seriously impacted, it may be time to look for help, more professional help. And in some cases, only professional help is going to be required to address more serious issues. You might need psychopharmacology and or other issues with medication. These are some real specific examples of times when it might be necessary to seek more professional help. A prolonged feeling of sadness, loss of interest in social activities, changes in sleeping and eating patterns, increased drug or alcohol use, auditory or visual hallucinations, extremely high emotional times, extreme highs, extreme lows, thoughts of self-harm or suicide, definitely, paranoia, and sometimes fatigue and lack of energy, not related at all to physical health conditions. Even weight loss or huge weight gains might be indications of a need to seek more professional help. And so that we do know that there's a need for policy advocacy as it relates to how we might increase access, particularly for Black people. And we need, the workforce is hugely, there's a huge problem in the workforce of available Black therapists and Black mental health professionals. We need to do a lot more work to increase the workforce. And I'm so glad that Xavier University and certainly Southern University is working to increase the availability of Black professionals who can provide mental and social health interventions.
Doc, we don't like to tell our business. What's our business is our business, Doc, But I think I do want to highlight just the importance of family therapy. But while family can provide familiarity, I think that clinicians can provide just a little more clarity, But let's go ahead and address these questions that are in the chat.
Okay.
Excuse me, J. Christopher. The questions were addressed in the chat. Dr. Gillard answered one and Nelson answered the other one. But I would like to thank you all for attending tonight, Dr. McLean, Dr. Castle, and Dr. Gillard. And closing remarks. Promoting diversity and supporting health equity is a top priority. The Southern University at New Orleans Millie M. Charles School of Social Work, Xavier University of Louisiana College of Pharmacy, and 7-Star Academy for the All of Us Research Program, thank you for participating in tonight's webinar. Special thanks to Dean Rebecca Chazon for her leadership in the Millie M. Charles School of Social Work, Dr. Derek Freeman for his creativity, support, and mentoring of All of Us Research Program scholars. All right, Doc. And to Dr. Katani Lemie for her consistency and drive throughout the planning of this webinar and my sorrow. And 7-Star Academy for the technical support and platform that made this webinar a success. Learn how the social determinants of health can help us understand how to be more inclusive and how the All of Us Research Program is building the most diverse health information database of its kind. Please visit joinallofus.org, Together New Orleans. Again, please visit joinallofus.org /Together New Orleans. Thank you and have a good night.